Hello, everyone. A very good evening. And today we will be discussing pulmonary medicine, a important system of internal medicine. Let everyone join in. How are you all doing? I hope you are all studying hard for the exam and you are all doing well. I hope everyone is filled up with full motivation to revise pulmonary medicine with me. So, in I have started the video. Okay. So in pulmonary medicine, we will be covering asthma, bronchiectasis, chronic obstructive pulmonary edema, interstitial lung disease, systemic sarcoidosis, hypersensitivity pneumonitis, pneumoconiosis, eosinophilic pulmonary syndromes, hypoxemia, ARDS, pulmonary hypertension, cor pulmonale, pulmonary thromboembolism, neoplasms, and the pulmonary sleep disorders. I want you people to be attentive throughout the lecture and be as interactive as possible throughout the lecture. Okay. So I need your feedback whether you are understanding or not. This is going to be a discussion class, a live class where you people will be interacting with me. Okay. Shall we start? Has everyone joined in? Okay. I think we can just start with the class. Rest of the students can join in later on. So many of the students are going to see it afterwards also. For them also, I would suggest please try to attend the live classes. They are more beneficial as compared to the classes which you see after the session ends. Good evening, everyone. Good evening, Nora. Good evening, Osama. Good evening, Inker Studio. Good evening, Asif. Good to see you all. Let's start with our discussion. Let's start with what do you mean by obstructive lung diseases? Okay. First of all, we will in this discussion we are going to cover about the obstructive lung diseases. Then we'll deal with the restrictive lung diseases, and then we'll discover more topics which are important in pulmonary medicine. Now, let's first understand the very important topic of obstructive lung diseases. Now, what is obstructive lung diseases? नाम से पता चल रहा है obstruction is happening or narrowing of the airway is happening. Narrowing of the airway is happening or the collapse of the airway is happening. Due to narrowing or collapse of the airway, what will happen? When airway will narrow or collapse, what will happen? The expiration cannot take properly, and that results in trapping of the air. So there is lot of trapping of the air happening inside the lungs in case of obstructive lung diseases, right? So these are your trachea, right? This is your bronchi, small bronchi, and further these bronchi are dividing into terminal bronchioles leading to alveoli. Now, if obstruction will happen due to any cause, whether there is narrowing of airway or collapse of airway, so what will happen? There will be trapping of the air distal to the obstruction. There will be trapping of the air distal to the obstruction, and this happens due to defective expiration that is there in obstructive lung diseases. I hope I am clear. Just put a thumbs up if you are understanding. Now, see, obstructive lung diseases are classified as asthma, bronchiectasis, COPD or cystic fibrosis, or foreign body obstruction. Okay, so in asthma, what is happening? Asthma, you will see there is narrowing of the airway in response to hypersensitivity. In bronchiectasis, what is happening? Due to inflammation, the mucus plug is coming and obstructing the bronchi. In COPD as well as cystic fibrosis also, there is inflammation of the bronchioles that is resulting in narrowing of the airway, and finally due to foreign body obstruction, you can get obstructive lung diseases. Now, one important point that I want to tell you is all the wheezes are not asthma. Okay, all the wheezes are not asthma. We all know, ठीक है, asthma में we get wheeze, right? We get wheeze. But remember, all wheezes are not asthma. Other conditions that can cause wheezes are foreign body inhalation and COPD. These are two other causes of wheezes. I hope I am clear. Now, please remember, in case of obstructive lung diseases, this FEV1 by FVC ratio is less than 70%. The FEV1 by FVC ratio is more than 70% in case of restrictive lung diseases. Okay, let's move to asthma. Now, before moving to asthma, I would like you to understand the graph. the graph of, just a second, the screen is stuck. Okay, so before moving to asthma, I would like to show you a graph. I would like to show you a graph showing various lung volumes and various capacity. Okay, so this is the graph which is showing you various lung capacities. Okay, this is a graph that is showing you various lung capacity. This is different lung volumes and the interpretation of pulmonary function test. We'll talk about that. We'll come to asthma and then we'll discuss what happens to the total lung capacity in asthma. Now look at this image. So this is showing you tidal volume. Okay, what is tidal volume? Tidal volume is the amount of air inspired or expired in normal respiration, that is approximately 500 ml. Okay, so this is tidal volume. Now this one is inspiratory reserve volume. So you can see inspiratory reserve volume, inspiratory reserve volume. This one is expiratory reserve volume, and finally we have the residual volume inside the lungs. Now what is inspiratory capacity? How do you calculate inspiratory capacity? Inspiratory capacity is inspiratory reserve volume plus tidal volume. Vital capacity is inspiratory capacity plus expiratory reserve volume. Okay, and the total lung capacity is equals to your inspiratory capacity plus FRC, or you can see all the volumes. If you will add up, that will give you the total lung capacity. This graph is clear. This graph is repeatedly asked in your exam. That is why you, from this graph, you will be able to solve many of the questions if you study it nicely. Okay, so let's now move to asthma. Let's now move to our discussion of asthma. Okay, look at this. Look at this. Okay, let's talk about asthma now. So what happens in asthma? Can anyone tell me what happens in asthma? So asthma is a condition of reversible airway obstruction. It is a condition of reversible airway obstruction that happens secondary to the bronchial hyperactivity. Okay, so there is airway obstruction due to bronchial hyperactivity, but this condition is reversible. There is lot of airway inflammation, there is mucus plugging and smooth muscle cells hypertrophy that will happen in asthma. So asthma is a type 1 hypersensitivity reaction. Here the airway will get inflamed, there will be lot of mucus plugging, smooth muscle hypertrophy that will be happening in asthma. It is a reversible condition that you have to remember, and it is a condition of bronchial hyperactivity. This point is important. Clear? Yes, there is bronchial hyperactivity and histamine release. Now, what are the symptoms of asthma? What are the symptoms of asthma? You get dry cough, you get episodic wheezing, you get dyspnea, and you get chest tightness. Now, these symptoms will worsen at night or early morning. These symptoms will be worsened in night and early morning. Clear? Clear? Now, let's move to the examination findings. Examination findings of asthma include, there is wheezing. So when the airway will be obstructed, and when the person will try to breathe and push the air out against the obstruction, there will be a sound heard that is known as wheeze. Okay, wheeze. So wheezing, prolonged expiration, and due to increase in respiratory effort, the patient will start to use his accessory muscles. So there is increased use of accessory muscle in a patient of asthma. There is tachypnea, there is tachycardia, there is hyperresonance, there is pulsus paradoxus. Yes, you can all add the points which you can remember. So this will be a collective discussion. अगर कुछ भी points यहाँ पे asthma से related, pathology से points if you want to add, you can add. So yes, there you can find Kirschmann spirals in the sputum. Kirschmann spiral is a sputum finding of asthma. Charcot Leyden crystal is also a finding of asthma. Yes. Okay. So, so you can see these are the symptoms of asthma: tachypnea, tachycardia. There is hyperresonance because lot of air trapping is happening. Lot of air trapping will result in hyperinflation of the lung, and that will result in hyperresonance. Okay, another feature is pulsus paradoxus in case of severe asthma. I hope you all know what is pulsus paradoxus. What is pulsus paradoxus? What is pulsus paradoxus? Come on, everyone. This is repeatedly asked in your exam. So I want this class to be a active recall class also and a discussion class also. It should not be a one way lecture ki I'm just giving a one way lecture and you people are not interacting. The learning will not happen in this way. The learning will always happen in two way. Okay, so it should be a two way interaction. Now coming to the late signs of asthma. What are the late signs of asthma? When the asthma will get severe, what will happen? The breath sounds will decrease. Breath sounds will decrease. There will be cyanosis. There will be decrease in oxygen saturation, and there will be a lot of hypercapnia, that is increase in PaCO2 value. This happens in late asthma. The breath sounds will be decreased. There will be cyanosis in the patient. Oxygen saturation will be decreased and PaCO2 will increase. So hypercapnia, cyanosis, decreased breath sound and decrease in oxygen saturation. This happens in late asthma. Okay, let's move to Samter's triad. Very frequently asked. This is simple. Samter's triad is aspirin exacerbated disease. Samter's triad is seen in aspirin related asthma. Okay, aspirin or NSAID induced asthma is characterized by Samter's triad. What all features are there in Samter's triad? There is asthma, there is chronic rhinosinusitis, and there is nasal polyps. So three features of Samter's triad: asthma, chronic rhinosinusitis, and nasal polyp. Okay, now please remember, Samter's triad is a pseudo-allergic reaction. It is not IgE mediated. This is a pseudo-allergic reaction. It is pseudo-allergic, no IgE levels increased. Samter's triad, remember, aspirin exacerbated disease. Okay, now coming to diagnosis. How do you diagnose? How do you diagnose the asthma? So best initial test for diagnosis of asthma is spirometry, pulmonary function test. If there is obstructive pattern, to diagnose the obstructive pattern, you will give SABA to the patient, short acting beta agonist. When you will give short acting beta agonist, then the obstruction will get reversed. So reversible obstruction by giving SABA, your diagnosis points towards asthma. Okay. Now coming to FEV1 FVC value. FEV1 by FVC value is less than 70%. FEV1 is decreased. FEV1 is decreased. Residual volume will be increased. I told you in obstructive lung condition, lot of air trapping will be happening. So the residual volume will be increasing. Yes, short acting beta agonists are salbutamol and salmeterol. Very good. Okay. So residual volume will be increased. Total lung capacity increased. The DLCO can be either normal or can be increased. Now there is increase in FEV1 value more than 12% on giving SABA. Okay, please remember the FEV1 value, they increase for more than 12% by giving SABA. Okay, these are the findings that you get on pulmonary function test in case of asthma. Please remember the findings in pulmonary function test. Revise with me. FEV1 by FVC less than 70%, increase in residual volume. The DLCO value will be normal or increased. Then there will be increase in FEV1 more than 12% on giving SABA, and another one that is decrease in FEV1. Okay, now in between exacerbation. So asthma doesn't occurs in a continuous fashion. It occurs in exacerbation. There are episodes of exacerbation. So during exacerbation, the PFT will be normal. The pulmonary function test will be normal. Can you please say about the drugs to avoid in asthma patient in other diseases? So those drugs which will cause bronchial hyper activity, that you need to avoid. Especially please remember that beta blockers should be avoided in asthma. Beta blockers, why they should be avoided in asthma? Because they will cause bronchial constriction. Beta blockers will be causing bronchial constriction. That is why the beta blockers are avoided in asthma. Okay. Yes. Let's move to the next thing, that is we perform a special test in case of asthma, that is methacholine challenge test. Okay, methacholine challenge test is used to see the bronchial hyperresponsiveness if asthma is suspected. If we are suspecting asthma in a patient but his pulmonary function tests are normal and we want to check for bronchial hyperresponsiveness, we will perform methacholine challenge test. On giving methacholine to the patient, you will see there is increase in so when this test will be called positive, methacholine, what it will do? Methacholine is a cholinergic agent. Cholinergic agent will cause bronchoconstriction. So if the FEV1 value will decrease more than 20%, then you will say methacholine challenge test test positive. Methacholine challenge test positive. I hope you are understanding. Everything is clear. Clear? Let's move to the next topic, that is childhood eczema is associated with asthma. Now eczema is also an allergic condition. Asthma is also an allergic condition. You all know eczema or atopic dermatitis. Atopic dermatitis, it is a hypersensitivity reaction, and childhood eczema will be associated with asthma. In many children who are having eczema, you will also get asthma. Now coming to ABG analysis in case of asthma. So ABG, arterial blood gas analysis, when you will perform, so you will find in early exacerbation of asthma there will be respiratory alkalosis. There will be respiratory alkalosis. Why there is respiratory alkalosis in early exacerbation of asthma? Because there is hyperventilation in case of early asthma. Lot of hyperventilation will happen. Patient will try to compensate for the obstruction by hyperventilating. So what will hyperventilation do? This will decrease the PaCO2 value, increase the pH, and will cause mild hypoxia. So there will be respiratory alkalosis in early asthma. So hyperventilation will result in lot of CO2 washout. So in early exacerbation, there will be respiratory alkalosis, pH will be increasing, mild hypoxemia, and decrease in PaCO2. In late asthma, in late or severe asthma, you will find there is impending respiratory failure. So the respiratory muscles will go in fatigue, and due to impending respiratory failure, there will be respiratory acidosis caused by inability to ventilate. So in early asthma, you will find respiratory alkalosis. In late asthma or severe asthma, due to impending respiratory failure or respiratory muscle fatigue, you will find that there is respiratory acidosis. Clear? Now on chest X-ray, the asthmatic lungs will give you a hyperinflated appearance, and there will be flattening of the diaphragm. Hyperinflated lungs on chest X-ray, big lungs, large lungs, hyperinflated, black lungs, that will be asthma. Okay. Yes, what did you not understand? What did you not understand? Can you be more specific? I will repeat that again. Now coming to the treatment part of asthma. Acute exacerbation of asthma. In acute exacerbation of asthma, the drug which is given is oxygen and short-acting beta agonist like your albuterol. You will give systemic glucocorticoids to the patient, and you will give short-acting beta agonist or ipratropium or magnesium in case of severe exacerbation of asthma. Okay. Now, never use ipratropium alone in asthma treatment. Please remember, ipratropium is never used alone in asthma treatment. Either it is combined with SABA or it is combined with glucocorticoids. Please remember, never use ipratropium alone in asthma treatment. Okay. Coming to intubation. Okay. So, treatment in case of acute exacerbation, you will give oxygen to the patient, you will give SABA to the patient, you will give systemic glucocorticoids, or you have to give ipratropium magnesium in case of severe exacerbation. And in severe cases, if you find that patient is going into cyanosis, कभी-कभी intubate भी करना पड़ सकता है patient को. So in severe cases, when patient is unable to maintain the respiratory effort, and patient is going into cyanosis, then you have to perform intubation. Okay. Yes, beta blockers are avoided in asthma because they cause bronchospasm. Okay. So let's move to the treatment of asthma. These are the GINA guidelines for asthma. So you can see the updated GINA guidelines for asthma. So let's look at this. Okay, so step 1 to 2, you have to give low dose inhalational corticosteroids and formoterol. Step 3, you will give low dose inhalational corticosteroids and formoterol, plus you will give put the patient on maintenance. Okay, and step 4, you have to give medium dose drugs. And for maintenance, again, you have to give inhalational corticosteroids and formoterol. Coming to step 5, you have to add LAMA, and you have to perform phenotypic assessment of the patient. This is the treatment. And in step 5, you give high dose inhalational corticosteroids and formoterol. Okay. This is about a controller and reliever as needed, low dose of inhalational corticosteroids, formoterol. Okay. Just a second. Now, controller and alternative reliever. Controller and alternative reliever. So, step 1, take inhalational corticosteroids whenever SABA is taken. Step 2, low dose corticosteroids. Step 3, low dose. Step 4, you give medium dose. And step 5, you give high dose. That is the treatment. I'll give you the PDF. Just go through the treatment once. Okay, these are the treatment guidelines. Thus, you have to remember that just you have to remember in step 1, 2, and 3, you give low dose inhalational corticosteroids and formoterol. In step 4, you give medium dose, and in step 5, you give LAMA. You will add LAMA in the patient. Okay. Now, what is severe asthma according to new GINA guidelines? Severe asthma means asthma which remains uncontrolled despite the optimized treatment with high dose inhalational corticosteroids and LABA. And asthma that requires high dose inhalational corticosteroids LABA to prevent it from becoming uncontrolled. That is severe asthma. That is severe asthma. Okay. Let's move to the next topic, that is bronchiectasis. Let's move to the next topic, that is bronchiectasis. Before moving to bronchiectasis, let me show you some graph related to obstructive and restrictive lung diseases. Obstructive and restrictive lung diseases. Just a second, I'll show you that graph which shows patterns of obstructive as well as restrictive lung diseases. Okay, where's that graph? Yes, this is the graph which is repeatedly asked in the exam. So, three types of graph. First of all, see the graph is plotted between the flow and the lung volume. Okay, this graph is plotted between the flow and the lung volume. The flow is calculated in liter per second during expiration and inspiration, and on x-axis you will plot the lung volumes. Now look at this. Normal flow is like normal graph will be like this. Okay, normal graph will be like this. Now this loop will shift to left in case of obstructive lung diseases, and this loop will shift to right in case of restrictive lung diseases. This loop will shift to right in restrictive, and loop will shift to left in case of obstructive lung diseases. That you have to remember. Okay, so what is happening in obstructive lung diseases? In obstructive lung diseases, the total lung capacity is remaining the same. The residual volume is increasing, and the flow is decreasing. In obstructive lung diseases, you can see the flow is decreasing. In restrictive also, the flow is decreasing. Right? But the loop will shift towards the right in restrictive lung diseases. I hope you must have studied these things in physiology. So go to the physiology part, revise once what happens, why this graph looks like this in obstructive lung diseases and why it looks like this in restrictive lung diseases. Okay, so just a second. Okay. So I hope I am clear, and let me just show you the diagram of how does your hyperinflated lungs will look like. Okay, so let me just show you the diagram. We'll talk about the different medications which are used in asthma one by one, and we'll study about the effects of each and every medication. We'll come to ipratropium also. Okay, don't worry about that. Don't worry about that. Okay, this is how the hyperinflated lungs will look to you. You can see that the lung volume has increased quite sufficiently. The heart has become very tubular, and you can see the lungs are, the diaphragm is looking very flattened to me. Okay, this is your hyperinflated lungs. Hyperinflated lungs. Let's come to the common medications which are used in asthma. Let me just find that table where I can teach you the common medications which are used in asthma. Okay. This is a table, very important in order to remember the different drugs which are used in asthma. Please revise with me. Beta 2 agonists are used. Okay. Beta 2 agonists are used in asthma. Beta 2 agonists which are used in asthma are albuterol and salmeterol. What will beta 2 agonists do? They will dilate the airway. They will dilate the airway. Beta 2 agonist will cause bronchodilation. So albuterol is short acting beta agonist and salmeterol is long acting beta agonist. These will relax the bronchial smooth muscle by acting on the beta 2 receptors. Salmeterol is used for maintenance therapy. Please remember. Next one is corticosteroids. Corticosteroids, inhaled corticosteroids are used as a first line treatment to control asthma. Then you can use beclomethasone, prednisone. What they will do? Corticosteroids will inhibit the synthesis of cytokines that is causing a lot of inflammation in the asthma patient. Next is muscarinic antagonist. Muscarinic antagonist like your ipratropium and tiotropium. So ipratropium is SAMA, that is short acting muscarinic antagonist, and tiotropium is long acting one. Now muscarinic antagonist क्या करते हैं? They will block the muscarinic receptors. They block the muscarinic receptor and they will prevent the bronchoconstriction. Methyl xanthines are also used in asthma. Methyl xanthines like theophylline, how does it cause bronchodilation? By three mechanisms. So theophylline will inhibit phosphodiesterase enzyme and will decrease the cyclic AMP levels. Okay, thereby decreasing the cyclic AMP levels and increase the cyclic AMP levels. So it will inhibit theophylline is inhibiting phosphodiesterase enzyme. Okay, theophylline is phosphodiesterase inhibitor. The theophylline usage, can you tell me the other mechanism of action of theophylline? The other mechanism of action of theophylline, very frequently asked, it is a drug with zero order kinetics. And can you tell me? See, inhalation, prednisolone, if given inhalational route, say corticosteroids when given in inhalational route, they can be used for acute asthma. But the inhalational corticosteroids are beclomethasone and prednisone, not prednisolone. Prednisolone is an oral drug. Now, the usage of methylxanthine or the usage of theophylline is limited because it causes cardiotoxicity and neurotoxicity, and it has a narrow therapeutic index. Coming to cromolyn. What does cromolyn do? Cromolyn will prevent the release of vasoactive mediators from the mast cells. Okay, it will prevent the release of vasoactive mediators like histamine and all from the mast cells. And cromolyn is useful for exercise-induced bronchospasm. It is effective for the maintenance of asthma and not effective during acute attack. Cromolyn cannot be given in acute attack. Toxicity of cromolyn is rare. Next drug is anti-leukotrienes. Anti-leukotriene mein Xeloton is used in asthma. Xeloton is a 5-lipoxygenase inhibitor that blocks the conversion of arachidonic acid to leukotrienes. And montelukast and zafidukast, what they do? They will block the leukotriene receptor. I hope I am clear. Xeloton is 5-lipoxygenase inhibitor, while montelukast is leukotriene receptor blocker. I hope I am clear. Next one is anti-IgE antibody omalizumab. Omalizumab is a monoclonal antibody against IgE. It inhibits the IgE binding to the IgE receptor on the mast cells and it is used in allergic asthma. And finally, anti-IL-5 antibodies, mepolizumab. Mepolizumab is monoclonal antibody against IL-5 and potent chemoattractant, which is a potent chemoattractant for eosinophils. Understood? Clear? Okay. Let's now move to, this was about the drugs which are used in asthma. Now move to bronchiectasis. Now coming to bronchiectasis. So what happens in bronchiectasis? Bronchiectasis में bronchus का recurrent infection और inflammation होता है. जब bronchus का recurrent infection और inflammation होगा तो bronchus का fibrosis होने लगेगा, remodeling होने लगेगी and permanent dilatation will happen at the level of bronchi. Okay, permanent dilatation will happen at the level of bronchi. So recurrent cycles of infection and inflammation of the bronchi will result in fibrosis of the bronchi, remodeling of the bronchi and permanent dilatation of the bronchi. What are the physical examination findings and what do you find in history in bronchiectasis? So in bronchiectasis, you will find chronic productive cough. Okay, chronic productive cough is a feature of bronchiectasis. Chronic productive cough. So the cough will be in frequent bouts and will be yellow-green in color. Yellow-green sputum will come out. Dyspnea and hemoptysis will be there. So chronic productive cough, yellow or green in color, dyspnea, hemoptysis, feature of bronchiectasis. Bronchiectasis is associated with cystic fibrosis and pulmonary infection. It is associated with cystic fibrosis and pulmonary infections associated with hypersensitivity, immunodeficiency, allergic bronchopulmonary aspergillosis, tuberculosis, non-tuberculous mycobacterium, that is Mycobacterium avium complex. Okay, these are the associations of bronchiectasis, cystic fibrosis, pulmonary infections, hypersensitivity, immunodeficiency, allergic bronchopulmonary aspergillosis, tuberculosis, non-tuberculous mycobacterium, that is Mycobacterium avium complex. Examination finding of bronchiectasis include rales, wheezes, rhonchi, and purulent mucus. Okay, these are the findings that you will get on examination: rales, wheezes, rhonchi, and purulent mucus. Now coming to the diagnosis part. So you can see since the bronchi are dilated in the bronchiectasis, the bronchovascular markings will increase. Tram lines will be seen. The tram lines are parallel lines, and tram lines means, what do tram lines represent? Tram lines represent the dilated bronchi. Dilated bronchi, and these why the bronchial walls are appearing thickening? Because there is a lot of peribronchial inflammation and fibrosis happening in case of bronchiectasis. So tram lines, tram lines are due to dilated bronchi associated with peribronchial inflammation and fibrosis. Most accurate test for bronchiectasis is which one? High resolution CT is the most accurate test. Dilated, you will find dilated airways. The airways will be larger than the pulmonary arteries, and you will find the ballooned cyst in mostly in the lower lobes. Spirometry or pulmonary function test findings are obstructive pattern with decreased FEV1 by FVC value. How do you treat bronchiectasis? You will give antibiotics to the patient. Antibiotics will decrease the bacterial load. You will give respiratory fluoroquinolones like levofloxacin and moxifloxacin. In allergic bronchopulmonary aspergillosis, you will give systemic glucocorticosteroids and antifungals like voriconazole and itraconazole. In you will try to maintain the bronchopulmonary hygiene of the patient. How bronchopulmonary hygiene of the patient is maintained? Advising cough promotion and postural drainage and chest physiotherapy. And surgery is by lobectomy. You perform lobectomy in case of severe bronchiectasis. So this was about bronchiectasis. This was about bronchiectasis. Let me just show you an image of bronchiectasis. Let me show you the CT image of bronchiectasis. This is the CT image showing you bronchiectasis. You can see the chest CT demonstrates the markedly dilated and thick walled airways. Markedly dilated airways, red arrows are showing you markedly dilated airways, thick walled airways, consistent with bronchiectasis. And bronchiectasis is associated with a very special condition, that is cystic fibrosis. It is associated with cystic fibrosis, allergic bronchopulmonary aspergillosis. Clear? Okay. Now let's move to the next topic, that is COPD. I just need 2 minute break and then I'll be back. I'll be back. Okay. I'm so sorry. I had to take a leave. I was not able to see your live uh, comments. I was not able to see the live chat due to some technical issues. Okay. Now the issue has been fixed and now I am able to see your live comments. Okay. So coming to next topic, that is COPD. Okay, so COPD. What do you understand by COPD? Chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease, which is a disease characterized by decrease in lung function associated with airway obstruction. So, in chronic obstructive pulmonary disease, the lung function is going to decrease due to airflow obstruction. This is divided into two major subtypes, that is chronic bronchitis and emphysema. Am I audible, everyone? Am I audible? I hope I am audible. Am I audible? Clear? Okay. So, chronic obstructive pulmonary disease is characterized by decrease in lung function associated with airway obstruction, and this can be divided into two major subtypes, that is chronic bronchitis and emphysema. Okay, so what is the definition of chronic bronchitis? Chronic bronchitis means there is productive cough for more than 3 months per year for 2 consecutive years. This is a clinical diagnosis. Chronic bronchitis is a clinical diagnosis. Please remember the definition: productive cough for more than 3 months per year for 2 consecutive years. Then emphysema. What is emphysema? In emphysema, you will find there is a lot of destruction and dilatation of the airway. Destruction and dilatation, and particularly this destruction and dilatation happens distal to the terminal bronchioles. It happens distal to the terminal bronchioles. And this can also happen secondary to smoking. When it is secondary to smoking, you will find centrilobular emphysema, and when it is due to alpha-1 trypsin and deficiency, then it is panlobular emphysema. Panlobular emphysema. So, I hope COPD, the definition is clear, the classification is clear. Okay. Coming to the history and physical examination findings of chronic obstructive pulmonary disease. So, symptoms are minimal in case of chronic obstructive pulmonary disease, or they can be non-specific until the disease has advanced. Okay, until the disease have advanced, the symptoms will be very minimal or non-specific. Now, the other things which you get is the clinical spectrum which you get is you will see barrel chest due to hyperinflation, you will see use of accessory muscles, you will see jugular venous distension and wheezing, dyspnea and muffled breath sounds. Dyspnea, muffled breath sounds, these are the findings of COPD, different findings of COPD. Okay. Let's come to the diagnosis part. How do you diagnose COPD? The best initial test for diagnosis of COPD, again, it is spirometry, that is pulmonary function test. In pulmonary function test, you will see a obstructive pattern, and this obstructive pattern is non-reversible by giving SABA. In case of asthma, the obstructive pattern was reversible by giving SABA. Here, the obstructive pattern is non-reversible with SABA. Okay. Now, FEV1 by FVC is less than 70% in case of chronic obstructive pulmonary disease. The FEV1 value is decreased. FEV1 value is decreased. FVC is normal or can be decreased. The residual volume is increased, and total lung capacity is also increased in case of COPD. When you will give SABA to the patient, there will be minimal change in FEV1. So minimal, less than 12% change or no change in FEV1 on giving SABA is the diagnosis of COPD. So minimal, less than 12% to no change in FEV1 on giving SABA is the diagnosis for COPD. Okay. The DLCO value will be decreased. DLCO is decreased in emphysema or late stage of COPD. Normal DLCO in case of chronic bronchitis. The DLCO remains normal in chronic bronchitis. It is decreased in emphysema and late stage COPD. Okay, it is decreased in emphysema and late stage COPD. The DLCO is normal in case of chronic bronchitis. This you have to remember. Now coming to the chest X-ray finding of the COPD. ठीक है, COPD में you will get hyperinflated lungs, you will get decreased lung markings with flat diaphragm, decreased lung marking, hyperinflated lung. The heart will appear like a tubular heart because lungs are very hyperinflated, so they will push the heart and heart will become very thin or tubular, and mediastinum thinning will be seen in case of COPD. Parenchymal bullae and subpleural blephs are pathognomic of COPD. Parenchymal bullae and subpleural blephs are also seen in COPD. Okay. Uh, on ABG, you will get hypoxemia, oxygen will be decreased with acute or chronic respiratory failure, respiratory acidosis, increase in PCO2 levels, and on Gram stain, if any bacterial infection is there, then Gram stain will be positive for that condition. And you will find fever, productive cough, and new infiltrate on chest X-ray. Now, coming to COPD and hypercapnia. Okay, COPD and hypercapnia. Now, what happens in COPD patient? We give supplemental oxygen, right? So there is hypoxia in the patient. So in order to treat hypoxia, we give supplemental oxygen to the patient, and we advise smoking cessation. Okay. Now, while giving excess supplemental oxygen to the patient, excess supplemental oxygen will do what? Will decrease the ventilatory drive, and when ventilatory drive will be decreased, that can worsen hypercapnia and can cause respiratory acidosis, can worsen the respiratory acidosis as well as worsen the hypercapnia when we give supplemental oxygen. So supplemental oxygen in case of COPD is a double-edged sword. It can decrease the hyper and ventilatory drive, worsening the hypercapnia and respiratory acidosis. Now, coming to alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency is generally seen in less than 60 year, minimal or no smoking history, and basilar predominant COPD is a feature of alpha-1 antitrypsin deficiency. Okay, alpha-1 antitrypsin deficiency, basilar predominant COPD. Clear? Any doubt? Now, how do you do the treatment of COPD? If you want to add something to this discussion, you are more than welcome to add. If you can recall something related to COPD here, related to emphysema, you are more than welcome to add anything you want to add. Now, treatment for COPD, you give corticosteroids, lot of inflammation happening. Oxygen is given. If SpO2 is less than 88% or less than 89%, prevention and dilators like beta-2 agonist and anticholinergics are given for the treatment of COPD. Okay, these are given for the treatment of COPD. Okay, let's come to emphysema. In emphysema, emphysema patients are also known as pink puffers. Okay, while chronic bronchitis patients are known as blue bloaters. Okay, so in emphysema, you will find a lot of blephs in the respiratory airway. This is type 1 respiratory failure associated with respiratory alkalosis. Air trapping will happen. Investigation of choice HRCT, and most common complication is cor pulmonale. Can you tell me what do you understand by cor pulmonale? Yes, there is increased risk of cor pulmonale. What do you understand by cor pulmonale? What is cor pulmonale? Anyone? Chronic bronchitis. In chronic bronchitis, there will be a history of smoking. There will be severe dyspnea. The respiratory rate will be increased. Accessory muscles will be used in excess. Pursed lip. So they will be blue bloaters. Central cyanosis, pursed lip, blue bloaters, and bronchovascular markings are increased. Treatment is antibiotics plus mucolytics, ipratropium bromide, and theophylline. This is the treatment, and we give low flow oxygen in case of chronic bronchitis with the help of nasal cannula. This low flow oxygen is given at the rate of 1 liter per minute or 16 hours per day. This amount of oxygen is given. Okay, in case of COPD. Okay, I will show you the image of a patient with COPD, the chest x-ray of a patient who came with COPD. So let's look at this. This is the lateral chest x-ray. Lateral chest x-ray, you can see the flattening of the diaphragm, right? So there is hyperinflation of the lung with large lung volumes, flattening of the diaphragm, and minimal peripheral vascular markings. Okay, I will show you the PA view also of this patient. So you can see the PA view. Here you can see that the bronchovascular markings have increased here, but peripheral markings have decreased, right? Peripheral vascular markings have decreased. Minimal peripheral vascular markings in case of COPD. Okay, due to hyperinflation, you will find minimal peripheral vascular markings. I hope I am clear. Any doubt regarding the chest X-ray? Any doubt? I will explain it again. Hyperinflation, flattening of the diaphragm, minimal peripheral chest markings. Yes, barrel shaped chest, I have told you in case of hyperinflation, because in case of hyperinflation, the AP diameter will be more as compared to the transverse diameter. That is why you get barrel shaped chest in case of COPD or asthma in any hyperinflated condition. Clear? Okay. Let me just show you the table. Okay, so emphysema, the two types of COPD are emphysema and another one is chronic bronchitis. Emphysema patients are known as pink puffers. In emphysema, there is terminal airway destruction and dilatation. The appearance of the patient in emphysema will be thin, wasted with pursed lips and minimal cough. And acid base status will be late hypercarbia or hypoxia, so the patient will be pink. So hypoxia and hypercarbia is a late finding of emphysema. Here you will get pink appearance of the patient. There will be no cyanosis. So pink puffers, emphysema. Chronic bronchitis nickname blue bloaters. Definition: productive cough for more than 3 months for 2 years. Overweight, fatty patient, edematous. Acid base status will be early hypercarbia or hypoxia. So, in early stages itself, the patient will develop cyanosis. The color of the patient will be blue due to cyanosis. Okay. Yes. This is the COPD treatment. Now coming to COPD treatment. In case of acute exacerbation of COPD, you will give supplemental oxygen. You will get supplemental oxygen and titrate the SpO2 levels to 88 to 92%. You will not give excess of oxygen, because what will excess of oxygen do? Excess of oxygen was decreasing the ventilatory drive, and when ventilatory drive will be decreasing, that will worsen the hypercapnia in the patient. That is why you have to titrate the SpO2 to 88 to 92%. You will not give excess of oxygen. In case of acute exacerbation, inhaled bronchodilators are given like SABA, albuterol, and anticholinergics ipratropium. Systemic corticosteroids like prednisone are given. You will add antibiotics if more than two cardinal symptoms are there, like dyspnea, cough, sputum production. In case of severe exacerbation, severe exacerbation of COPD is characterized by respiratory failure, severe hypoxemia or respiratory acidosis, and altered mental status. In severe exacerbation of COPD, give non-invasive positive pressure ventilation with BiPAP first. Non-invasive positive pressure ventilation with BiPAP. And if NPPV will fail, next step will be you have to intubate the patient. This is the treatment of acute exacerbation of COPD. Coming to chronic COPD. Chronic COPD, how you will treat the patient? Perform lifestyle modifications like smoking, give pneumococcal vaccine to the patient, influenza vaccine to the patient. Now, pneumococcal vaccine, please remember, pneumococcal vaccine में PPSV23 polysaccharide vaccine है और PCV13 conjugate vaccine है. Okay, in less than 65 years of age, you give PPSV23 alone. In more than 65 years of age, you will give PCV13 plus PPSV23. And in all the ages, influenza vaccine should be given, because there is increased risk of developing infection in chronic COPD patient. Inhaled bronchodilators will be given. Then, if more than two exacerbations are there in COPD, you will consider adding inhalational corticosteroids. Long-term oxygen therapy is given. Long-term oxygen therapy is only indicated if SpO2 is less than 88% or PaO2 is less than 55 millimeter of mercury, or SpO2 less than 89% or PaO2 less than 59 millimeter of mercury, and there is evidence of cor pulmonale, right heart failure, or polycythemia is present. And supplemental oxygen can worsen the hypercapnia, that you have to remember. So goal oxygen saturation will be 90 to 93%. Yes, Reed index is used in chronic bronchitis. Yes, very good. What is Reed index? How do you calculate Reed index? Reed index is the thickness of the gland divided by thickness of the wall. Thickness of the gland divided by thickness of the wall. Very good. Yes. Yes, very good. Cor pulmonale is right-sided heart failure. Gene involved BMPR2. NPPV is the treatment. Tracheal intubation. Very good. Okay. Now let's just move to the main slide. That is, now let's discuss restrictive lung diseases. Let's discuss restrictive lung diseases quickly. The etiology of restrictive lung diseases is you will get alveolar edema, hemorrhage, and pus. You will get the causes. Okay, sorry. The what are the different causes of restrictive lung diseases? Causes of restrictive lung diseases include alveolar causes, that is edema, hemorrhage, pus, interstitial lung disease, inflammatory conditions like sarcoidosis, cryptogenic organizing pneumonia, idiopathic pulmonary fibrosis, neuromuscular causes like myasthenia, phrenic nerve palsy, myopathy, and thoracic wall causes like kyphoscoliosis, obesity, ascites, pregnancy, and ankylosing spondylitis. So, what do you understand by restrictive lung disease? What do you understand by restrictive lung disease? Restrictive lung disease, in case of restrictive lung disease, the lung compliance will be decreased. Lung compliance will be decreased, and there is increase in lung stiffness and decrease in lung expansion. Okay, lung becomes more stiff and the lung expansion is less in case of restrictive lung diseases. The etiology I have already discussed with you. What are the different causes of restrictive lung diseases? The different causes can be remembered by the mnemonic AINT. Okay, AINT is the mnemonic for remembering restrictive lung diseases. That is alveolar causes like edema, hemorrhage, pus, interstitial, inflammatory, idiopathic pulmonary fibrosis, neuromuscular causes, and thoracic wall causes. These are the different causes of restrictive lung diseases. Okay. So now coming to interstitial lung disease. What are interstitial lung disease? Interstitial lung disease are a group of disorders characterized by inflammation and fibrosis of the interstitium. So here there is a lot of fibrosis of the interstitium that will happen. And in case of advanced interstitial lung disease, you will find cystic spaces will develop in the periphery of the lung. Cystic spaces will be seen in the periphery of the lung. The cystic spaces seen in the periphery of the lung give a characteristic honeycomb appearance on CT. Why do you find honeycombing in interstitial lung diseases? Because in advanced interstitial lung diseases, what will happen? Cystic spaces will develop in the periphery of the lung that will give honeycomb pattern. Interstitial lung disease is also known as by the name of DLPD, DPLD, that is diffuse parenchymal lung disease. Diffuse parenchymal lung disease. Now, let's understand the different subgroups of interstitial lung disease. There are exposure related interstitial lung disease which will develop after exposure to certain agents like asbestosis, silicosis, berylliosis, coal worker pneumoconiosis, some medications like amiodarone and bleomycin, and hypersensitivity pneumonitis. These are the exposure related cause of interstitial lung disease. Now, interstitial lung disease which are associated with systemic disease or connective tissue diseases include polymyositis, dermatomyositis, sarcoidosis, amyloidosis, vasculitis, and Cres syndrome. Idiopathic pulmonary fibrosis, idiopathic condition associated with interstitial lung disease include idiopathic pulmonary fibrosis, cryptogenic organizing pneumonia, and acute interstitial pneumonia. These are all the different types of interstitial lung diseases. Now, there are some medications which can lead to interstitial lung diseases. Can you name the medications which can lead to interstitial lung diseases? These include amiodarone. Okay, I have told you bleomycin is there, bleomycin, nitrofurantoin, busulfan, methotrexate, then radiation, and long-term oxygen concentration. This can cause pulmonary fibrosis and result in interstitial lung disease. Clear? Yes, very good. Amiodarone, bleomycin, busulfan, and methotrexate. Difference between fibrosis and sclerosis. Okay, so in sclerosis, there is these are pathological findings. So in systemic sclerosis, you will get fibrosis of the lungs. Sclerosis is different, and sclerosis is generally thickening And fibrosis is deposition of the fibrin material. It is deposition of the fibroblast. It is deposition of the collagen, deposition of the fibrin. That is fibrosis. Okay. Now, let's come to the history and physical examination findings of the interstitial lung disease. So in interstitial lung disease, I told you there will be stiffness of the lung. So due to lung becoming stiff, lot of fibrosis happening inside the lung. What will happen? The breath of the patient will become shallow. There will be rapid breathing, progressive dyspnea on exertion, chronic non-productive cough, shallow breathing, rapid breathing, progressive dyspnea on exertion, cyanosis, inspiratory squeaks, fine or velcro like crackles, and clubbing or right heart failure. So velcro like crackles or fine crackle is a feature of interstitial lung disease. Cyanosis is a feature of interstitial lung disease. Inspiratory squeaks, chronic non-productive cough, and shallow rapid breathing and dyspnea on exertion. These are all features of interstitial lung disease. Okay. Now coming to the diagnosis. How do you diagnose interstitial lung disease? You will perform a chest x-ray. On chest x-ray, you will find reticular opacities, nodular opacity, or ground glass pattern. So if you are finding reticular opacities, nodular opacity, or ground glass pattern, then chest x-ray, on chest x-ray, then it suggests interstitial lung disease. Next best step is, if chest x-ray is suspicious of interstitial lung disease, go for high resolution CT. In high resolution CT, you will see honeycombing pattern. Honeycombing pattern if the disease is severe. Okay. So I'll show you the chest CT image of interstitial pulmonary fibrosis. Don't worry about that. But these are the findings that you get in interstitial lung disease. I'll move to that. Now, what are the pulmonary function test findings in interstitial lung disease? Interstitial lung disease will present like a restrictive pattern of lung disease. So you will get increase in FEV1 or FVC value, decrease in FVC value, decrease in FEV1 value. Everything is decreased. You can see all the findings on pulmonary function test are decreased. If you are suspecting systemic disease, then you need to perform serology. You need to perform AN antibody, anti-CCP antibody, cytokinins you have to perform, CK, then aldolase, anti-Jo1, ANCA, anti-topoisomerase, and anti-dsDNA antibodies. These are the different antibodies you need to perform if you are suspecting systemic disease. Most accurate test if it is asked for interstitial lung disease, it is surgical biopsy, that will confirm the diagnosis of idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis. Treatment of interstitial lung disease: give anti-inflammatory drugs like corticosteroids, anti-fibrotic agents like pirfenidone and nintedanib. Okay, let me just show you the image of interstitial lung disease. So okay, don't worry, we will discuss some of the great important images repeatedly asked in the exam, and from the images it will be clear about the pathology findings also. So look at this image. This image is showing you what? First one is showing you chest CT and showing you characteristic honeycombing pattern in the periphery. Which is seen in advanced stage of idiopathic pulmonary fibrosis. And second image is a image of lung biopsy specimen that is demonstrating increased interstitial fibrosis and non-specific inflammation with alveolar thickening. Right? You can see increased interstitial fibrosis, lot of interstitial fibrosis happening, and non-specific inflammation with alveolar thickening. These are the features of idiopathic pulmonary fibrosis. Clear? Now let's just study some of the pneumoconiosis. I told you exposure related pulmonary fibrosis can happen. So asbestosis. Let's see. Asbestosis is associated with asbestosis is generally seen in people who work in the manufacturing industry of tile industry, brake lining industry, insulation industry, construction, shipbuilding industry. Okay, so 15 to 20 years after exposure to asbestosis, the patient will develop the signs of asbestosis. Now, imaging findings of asbestosis, what you will see? You will see linear opacities at the lung basis. So, asbestosis is localized to the base of the lung. So you'll see linear opacities at lung bases and interstitial fibrosis. There will be calcified pleural plaques which are indicative of benign pleural disease, and you will see ferruginous bodies in alveolar septum. These are the imaging findings of asbestosis. Imaging finding of asbestosis, revise with me, you will see linear opacities at the lung bases, calcified pleural plaques and ferruginous bodies in the alveolar septum. Complications of asbestosis, there is increased risk of mesothelioma and lung cancer. The risk of lung cancer is high in smoker, and most common malignancy which is seen in association with asbestosis, bronchogenic carcinoma. Most common malignancy associated with asbestos exposure is bronchogenic carcinoma. Okay, next one is coal workers disease. Let's understand coal workers disease. It is seen in people who work in underground coal mines, and you will find small nodular opacities in the upper lung zone. Okay, coal worker is localized to upper lung zone, small nodular opacity in upper lung zone. And complication is progressive massive fibrosis is a complication of coal worker disease. Next one is silicosis. Silicosis is seen in patients not patients. Silicosis is seen in workers who work in mine industries, quarries, or in glass or pottery industry. Okay, and in case of silicosis, you will see small nodular opacities in the upper lung zone. Small nodular opacities in the upper lung zone and eggshell calcifications. Small nodular opacity, upper lung zone, eggshell calcifications. Silicosis is associated with increased risk of TB. So you need annual TB skin test, and complication can be progressive massive fibrosis. Dumbbell shaped bodies, ferruginous bodies, yes, good. Okay. Thick fibrotic pleura is a feature of base of the lung involved. That is a feature of asbestosis. Okay. Now coming to berylliosis. Berylliosis is seen in people who work in high technology fields like aerospace industry, nuclear industry, electronic plants, ceramic industry, foundries, dental material sites. Okay, and you will see diffuse infiltrates in case of berylliosis and hilar adenopathy. Diffuse infiltrates in berylliosis and hilar adenopathy in berylliosis. And how to treat berylliosis? You have to give chronic corticosteroid treatment in case of berylliosis. So this was about the diagnosis of pneumoconiosis. Let's see the different images associated with pneumoconiosis. Now, what is this first image showing you? What is this first image showing you? First image is of the pleural plaques in case of asbestosis. These are the pleural plaques that you get in case of asbestosis. These are calcified pleural plaques in asbestosis. Okay, CT image showing you calcified pleural plaques in asbestosis. Image C showing you ferruginous body. This is how ferruginous bodies will look like. Dumbbell shaped body. Ferruginous bodies are seen in alveolar sputum. And this is a finding of asbestosis again. Asbestosis. Okay. So these images were important. I hope it's clear. Any doubt? Shall I move further? Then we'll discuss about systemic sarcoidosis. Systemic sarcoidosis. Okay, so systemic sarcoidosis is a multi-system disease involving different systems. It is of unknown etiology, and you will find non-caseating granulomas in various organs in systemic sarcoidosis. Okay, now how does systemic sarcoidosis patient present to you when there is lung involvement? In lung, you will find non-caseating granulomas in the lung, and when lungs will get involved, so the symptoms will be fever, cough, dyspnea, malaise, weight loss and arthritis. And ठीक है, अगर हिस्ट्री में he is giving you fever, cough, dyspnea, malaise, weight loss and arthritis, think about systemic sarcoidosis, because in systemic sarcoidosis there is joint involvement also. What is Lofgren syndrome? Lofgren syndrome is a type of systemic sarcoidosis where you get erythema nodosum, hilar adenopathy, migratory polyarthralgia, and fever. Erythema nodosum, hilar adenopathy, migratory polyarthralgia, and fever is a feature of Lofgren syndrome. And extra pulmonary manifestations of systemic sclerosis, sarcoidosis involve extra pulmonary manifestation, liver involvement, eye involvement. In skin, you are getting erythema nodosum, which is a violaceous skin plaque. Then third degree heart block and kidney involvement. Okay, so please remember the features of sarcoidosis by the mnemonic grueling. Grueling is the mnemonic for sarcoidosis. So you get granulomas in sarcoidosis, you get arthritis in sarcoidosis, you get uveitis in sarcoidosis, you get erythema nodosum, lymphadenopathy, that is particularly hilar lymphadenopathy, and you get interstitial fibrosis, you get negative TB test, and you get gamma globinemia in case of sarcoidosis. Okay, now how do you perform the diagnosis of sarcoidosis? In chest x-ray, you will find bilateral hilar adenopathy and reticular opacities which are predominant in the upper lobe. Reticular opacities which are predominant in the upper lobe associated with hilar adenopathy. This will suggest point towards sarcoidosis, bilateral hilar adenopathy with reticular opacities which are predominant in the upper lobe. High resolution CT is done for if chest X-ray is suspicious. Okay, HRCT is done if chest X-ray is suspicious. You can also go for lymph node biopsy. In lymph node biopsy, you will find non-caseating granulomas which are diagnostic of systemic sarcoidosis. And finally, the pulmonary function test. Okay, put a thumbs up if everything is clear. Also, it is a kind request to you people that please let me know in the comment section the feedbacks about how I can improve on my teaching, and if you people are actually understanding what I am explaining to you. So please let me know in the comment section. You are all welcome to any feedbacks you have for if how I can improve myself. Okay, put a thumbs up if I am clear. And what else can I add to the lectures in order to make it more efficient for you people to understand? Hello, Vrushali. The timing of the class will be around 4 p.m. 4 p.m. alternate day fixed here. Okay, you can watch the previous lectures as well. You can go and watch the previous lectures. Internal medicine की बहुत सारी classes complete हो चुकी है. Please go and watch the internal medicine lectures. Okay, it's there in the playlist of the channel. You can go and watch the other classes also of the internal medicine. The classes will be happening on alternate day at 4 p.m. Okay, thank you so much, Puneet. Okay, now what is the next step? What is the next step? When chest x-ray is suspicious of sarcoidosis, you will perform CT, and you can go for lymph node biopsy. In lymph node biopsy, you will find non-caseating granuloma which are diagnostic of the sarcoidosis. Now, PFT, pulmonary function test, will show restrictive pattern of the disease and decrease in DLCO value. And please remember Lofgren syndrome, which is seen in sarcoidosis, which is a type of sarcoidosis. You see a triad in Lofgren syndrome. The triad of Lofgren syndrome, remember, arthritis, erythema nodosum, and bilateral hilar lymphadenopathy. This is the triad of Lofgren syndrome. Okay. Other findings that you see in sarcoidosis, can you tell me? If you want to add anything, most welcome. We are all here to learn. Even I am a human, I am not perfect. So if you want to add something, you can openly tell me in the live chat section. Okay ma'am, कि ये चीज रह गई है, ये point miss हो गया है, so I'll just add it there. Thank you so much. I hope you get through the FMG exam. I'll be there with you till your FMG exam. Okay, now look at this pulmonary function test. The other findings which are seen in sarcoidosis, first one is the serum ACE levels serum ACE levels are increased in case of sarcoidosis. But serum ACE levels are neither sensitive nor specific for diagnosis of sarcoidosis. Second is hypercalcemia and hypercalciuria. You get increase in calcium levels. You get increase in calcium levels in the serum as well as in the urine in case of sarcoidosis. Alkaline phosphatase levels are increased with liver involvement. Lymphopenia is there, and cranial nerve defects is a finding of sarcoidosis. Okay. So coming to the treatment part of sarcoidosis, if the patient is symptomatic, give systemic corticosteroids. If the patient is refractory to systemic corticosteroids, go for immunosuppressants like methotrexate, azathioprine, and TNF alpha inhibitor. And in Lofgren syndrome, we have to give NSAIDs and supportive therapy in order to ease the joint pain. Now coming to hypersensitivity pneumonitis, I'll be now quick. Hypersensitivity pneumonitis is characterized by alveolar thickening and non-caseating granulomas secondary to mold, hot tub and birds, and it is secondary to down feather antigens. It will develop in response to hypersensitivity. It is a hypersensitivity reaction. So you'll find non-caseating granulomas will develop in the lung secondary to environmental exposure of mold, hot tubs, bird, down feather antigens. And the symptoms I have written here: dyspnea, fever, malaise, shivering, cough will start 4 to 6 hours after exposure. You'll get bilateral rales in case of chronic hypersensitivity pneumonitis. On chest x-ray, there will be upper lobe fibrosis, and treatment is by giving corticosteroids. Corticosteroids will decrease the inflammation. Pneumoconiosis we have discussed. Now next topic is eosinophilic pulmonary. Eosinophilic. Okay, thank you so much. After this video ends, please do write in the comment section also. I really need your feedbacks. Apart from the live chat, please do write in the comment section also. What do you particularly like about my teaching and how I can improve? Okay, now eosinophilic pulmonary syndromes. Eosinophilic pulmonary syndrome is a group of disorders where you will get abnormal peripheral blood eosinophilia. Okay, so eosinophils will be increased in the peripheral blood. Eosinophils will be increased when you will perform bronchoalveolar lavage more than 25%. And this is a eosinophilic pulmonary syndrome is a group of disorder where you will see a lot of pulmonary infiltrates, and these pulmonary infiltrates are eosinophilic. Okay, a lot of eosinophils will get deposited in the lungs, in the blood. You will find eosinophilia in bronchoalveolar lavage also. You will find more than 25% of eosinophils. What are the different causes of eosinophilic pulmonary syndromes? ABPA, allergic bronchopulmonary aspergillosis, Loeffler syndrome, which is seen in ascariasis, acute eosinophilic pneumonia, and drug-induced, that is due to NSAIDs, nitrofurantoin, and sulfonamides. NSAIDs, nitrofurantoin, and sulfonamides. Thank you so much. Really good to see. Okay, so drug-induced eosinophilic pulmonary syndromes include NSAIDs, nitrofurantoin, and sulfonamides. Now coming to the history of eosinophilic pulmonary syndromes. Eosinophilic pulmonary syndrome will present with dyspnea, cough, and blood-tinged sputum and fever. These are the findings of eosinophilic pulmonary syndrome. Diagnosis. How do you perform the diagnosis? You will find on CBC eosinophil count increased होगा. Chest X-ray में pulmonary infiltrates मिलेंगे. Bronchoalveolar lavage eosinophils will be more than 25%. Okay, and how do you treat eosinophilic pulmonary syndrome? Give corticosteroids to the patient. Okay, next one is ARDS. Let's revise about ARDS. So ARDS is characterized by decrease in PaO2 value. Okay, acute respiratory failure. Acute respiratory failure is different. ARDS is different. Okay, acute respiratory failure, we'll take it afterwards. Now let's talk about ARDS first. ARDS is also a cause of acute. It is a cause of acute respiratory failure. This is the condition of acute respiratory failure. Okay, now ARDS is characterized by respiratory failure with refractory hypoxemia which is not responding to anything. The lung compliance will be decreased and there will be non-cardiogenic pulmonary edema not associated with any cardiogenic cause. So there will be non-cardiogenic pulmonary edema, and the PaO2 by FiO2 value, you have to remember, will be less than 300 in case of ARDS. Pathogenesis is thought to be dependent on endothelial injury. So what happens in ARDS? Due to any trigger or any infection, the endothelium will be damaged, and when endothelium will be damaged, that will result in lot of inflammation. So endothelial injury, lung injury, alveolar injury is a cause of ARDS. So common triggers of ARDS, most common is sepsis, then pneumonia, aspiration, multiple blood transfusion, inhaled toxin, drowning, and trauma. These are the different causes of ARDS, and the mortality is very high in ARDS, that is 30 to 40%. And how does ARDS presents? ARDS presents with acute onset of respiratory failure within 12 to 48 hours of the triggering agent. You will get tachypnea, dyspnea, tachycardia, fever, cyanosis, labored breathing, diffused high-pitched rales in the patient. Now, there are different phases of ARDS frequently asked in the exam. What are the different phases of ARDS? Yes, you will get bilateral lung infiltrates. I will come to that. So, different phases of ARDS. There is a phase 1 of acute injury. In phase 1 of ARDS, you will find the physical exam will be normal and there will be possible respiratory alkalosis, only possible respiratory alkalosis. Phase 2 of ARDS, that lasts for 6 to 48 hours, will start from 6 to 48 hours after the injury. There will be hyperventilation, hypocapnia, and widening of the arterial and alveolar gradient. Okay, phase 3 of ARDS will consist of acute respiratory failure, tachypnea, dyspnea, decrease in lung compliance, all the severe findings, all the symptoms are coming in phase 3. There is acute respiratory failure, there is tachypnea, dyspnea, decrease in lung compliance, scattered rales, diffuse chest opacity, diffuse infiltrates are also coming in the phase 3 of ARDS. Till phase 2 of ARDS, you are not getting anything, you are just getting hyperventilation and hypocapnia and widening of the AA gradient. While in phase 3, all the signs and symptoms of ARDS will start appearing, that is acute respiratory failure, tachypnea, dyspnea, decrease in lung compliance, rales, diffuse chest opacity on chest x-ray. Finally is the phase 4 of ARDS. In phase 4 of ARDS, you will get severe hypoxemia, that is unresponsive to therapy, and increase in pulmonary, shunting, metabolic, and respiratory acidosis. Now you will get respiratory acidosis. Severe hypoxemia, which is unresponsive to therapy, increase in intrapulmonary shunting, and metabolic and respiratory acidosis is a characteristic of phase 4. Now, how do you perform diagnosis for ARDS? There is Berlin criteria for diagnosis of ARDS. Acute onset. If there is acute onset of respiratory distress that has developed within 1 week, less than 1 week, then you will suspect ARDS. You will find ground glass appearance on chest x-ray. Ground glass appearance on chest x-ray with bilateral alveolar infiltrate, which is inconsistent with any other cause of pulmonary edema, is suggestive of ARDS. So if pulmonary edema is developing on the chest x-ray within less than 24 hours after insult, will suggest pulmonary contusion instead of ARDS. Okay, so if pulmonary infiltrates, please understand this, if pulmonary infiltrates are developing, if pulmonary infiltrates are developing on chest x-ray within 24 hours, then you will suspect pulmonary contusion, not ARDS. In ARDS, these bilateral alveolar infiltrates will develop. We have studied after 48 hours. They will develop after 48 hours. Okay. The PaO2 to FiO2 value will be less than 300 with positive end expiratory pressure, and the PEEP and CPAP value will be more than 5 centimeter of water in case of ARDS. So these are the different findings that you get in ARDS. Respiratory failure that cannot be explained by heart failure. Treatment of ARDS, treat the underlying cause. Mechanical ventilation is given. Low tidal volume is given. How much amount of tidal volume is given in mechanical ventilation of ARDS? 4 to 6 cc per kg of the ideal body weight, to minimize the ventilator-induced injury by overdistension of the alveoli in ARDS patient. Use positive end expiratory pressure to recruit the collapsed alveoli. You will use positive end expiratory pressure to recruit the collapsed alveoli, and you will titrate positive end expiratory pressure and FiO2 to achieve adequate oxygenation. Okay. Keep FiO2 less than 60% if possible to prevent oxygen toxicity. And the goal oxygenation of PaO2 should be, the goal oxygen level should be more than 55 millimeter of mercury, or SpO2 level should be more than 88%. Okay, this is the goal oxygenation in case of ARDS and SpO2 more than 88%. Extubation is attempted in case of ARDS if the cause of respiratory failure has been improved, ventilatory support required is minimal, and oxygen supplementation is easily accomplished without the support of PEEP, then you can perform extubation in the patient. Okay, let me just to show you the image of infiltrates seen in ARDS patient. This is the image showing you AP view, showing you diffuse alveolar filling pattern. You can see diffuse alveolar filling pattern. This is ARDS. Okay. Okay. Clear? That's all for today's lecture. That's all for Thank you so much. That's all for today's lecture. Stay tuned. Some of the topics are left. I will try to cover in another lecture. In another lecture, we will cover some part of pulmonary medicine which is left, as well as the new topic will be covered in the next lecture, which will be happening day after tomorrow. Okay. So pulmonary thromboembolism, lung cancer, these topics are left. We'll cover in another class and then start with the next system also. Thank you for watching. Thank you so much everyone for your patience, and please don't forget to revise all this. I'll provide the PDF. Don't worry about that. It's important that you just revise the class after you are attending the class. So I have explained so many topics of pulmonary medicine in just a single lecture. Let's just go back and see what we have covered. Asthma we have covered, bronchiectasis, COPD, interstitial lung disease, this all we have covered, this we have covered, right? We have covered this. Now only these topics are left in pulmonary medicine. This we'll cover in the next lecture. Please go and revise all of them, because if you don't revise, everything will just vanish from your brain. Okay, revision is important, and I would like you people to be more attentive in the class rather than focusing on making notes. Notes is important. You can keep a copy and just note down the important points. So note taking भी एक art है, right? So when you are watching the lecture, सब कुछ नहीं लिखना होता है. आपको lecture में से filter out करना है कि what is important, and you have to write it down. Okay, so note taking में just don't write whatever I am saying. Just try to understand whatever I am explaining. Yes, for everyone, revision is important. And while the lecture, don't try to write everything down. Just do this thing. Try to understand whatever I am explaining and just write down the important things. Just write down the important things which you feel like. Thank you so much, everyone. That's all for today's class. All the very best, and keep learning, keep revising, and keep increasing your knowledge. Thank you.